that all should be up and running. But Kush, thanks for doing this. Nice to meet you, man. And why don't we just start off with your position at the moment, introduce yourself, and yeah, we can just go through how you like got into medicine and now how you're doing all this ED regging stuff. So yeah.
I'm Kush. I'm an emergency registrar at like Liverpool Hospital, so like in Western Sydney. I've been doing that for around 2 years now. Um, yeah, and really enjoying it. I think like it's a lot of different like pathology and stuff that we see, and like very broad. I mean, yeah, really enjoying that, and loving it.
That's awesome. And just to clarify, you're like on the ED program. You're like like training to be a FACEM, correct? Yeah.
Yeah. So this is the first year that you can join the program, and I sort of joined immediately, and then I just started like doing my primaries. I finished the primary like written exam, found out I passed like 2 days ago, which was really good. And then yeah, we're preparing for the Viva in like 3 months.
Amazing. Well, like congrats. That's a big first step, right? The written exams are always like that first hurdle for a lot of all these specialties to get through, and then it's the real nitty gritty stuff with the Viva, right?
Yeah, exactly. And then it's like even more sort of you got to know the concepts a bit better, and yeah, it can be a bit more like daunting to be able to recite everything off the top of your head. But yeah, it's like a few different hurdles at the beginning, and then you still got to get through like all the other requirements and stuff. Yeah.
Oh man, it's so many different things for each different specialty. But like how'd you find getting onto like the ED training program? I know you probably hear about like different like surge specialties having like all these hurdles and maybe some other ones as well having a bit of like tricky stuff that you need to do beforehand. But I've heard ED is not too bad. Like I don't know what your experience is like getting on.
Yeah, I think it's more about like deciding that you want to do it and being certain about that you want to do emergency. Like it's not like I think everyone like generally likes it in medical school, and that's how they start off. And I think that's how I start off as well, because it's the first time in medical school when you're able to do your own cannulas and like actually see patients and work up, and there's that mystery about the diagnosis and stuff like that. And then after that, I think it gets more and more sort of the mystery is the thing that starts fatiguing people, and like not knowing what's going to come through the door. So I think that's probably the most important thing, like as in knowing that this is definitely what you want to do. Um, and honestly, getting on the program is not so difficult. There's a lot of emergency registrar jobs everywhere because they need them, and they need them to staff their departments. And I think that's also the draw card for emergency medicine was also the fact that how flexible it is. So, like in terms of training, you can always do like part-time training and things like that. So even when you apply, there's a few requirements that you have to set up, and I think they've added a year on, like in around 2022. So you have to do like an unaccredited, like an SRMO year, like after residency, like PGY3. So you do like a non-accredited year. We have to do 6 months of ED, and then apply onto the program sort of that year. And that's when. So this is like my second year being a like part of the. I was first year being part of the ED training program, but like second year just doing sort of emergency medicine. Yeah.
I feel like most specialties are going that way, to be honest, having this like, unaccredited like registrar year or a sort of resident, like a mixture of like a resident and a registrar, sort of like a registrar with your training wheels on, which is probably not the worst thing in the world. I think it just gives you confidence because I'm doing my first unaccredited reg year now. And I mean, you sort of try to do it when you're a resident, but now you've got like the actual responsibility. It's like it's a big step up, but you almost need it before you can, get onto the program. I think, to be honest.
Yeah, I thought it was a huge step up. Like last year, I was like, I probably spent like 6 months just trying to like take it all in as a like a registrar. Like it's quite difficult to have so many things being like almost bombarded with you, and even where we work, like in Liverpool, is quite busy at the same time. So I think yeah, I was really lucky that if I'd be studying, like if this would have been the same period last year, then I'd be studying at the same time. Like if we didn't have that extra year, and that'd be even more difficult, I think. And like generally, I've had a lot of other sort of interests, like outside of medicine, and I feel like last year that was so difficult to sort of pursue.
Yeah, that's interesting that you say that like ED is pretty like flexible as well in the actual training program. I know like anytime like I was doing like a shift in ED, they were like so specific about the breaks. They were so specific about who's rostered here and there. It's quite good. You don't feel like this overwhelming sense that like on a surge rotation that you could work and miss not have a lunch break all week, and that would be normal. So
It's interesting you bring that up because my number one like thing about being an ED registrar is like you're probably the registrar that spends the least amount of time in the hospital because you're not going to be doing overtime. You clock on and you shift and you clock out as compared to a medical registrar or a surgical registrar that has to be doing after hours and overtime. He's probably spend the least amount of time. And actually, I was catching up with a few medical school like mates a few days ago, and they were showing like we're just comparing pay slips, and one of the surgical registrars is doing ENT. His payslip was through the roof because of on calls and things that he's been just been calling in all the time and sleeping at hospital. And I just realized how much more work than everyone else is doing in being at hospital.
it's an interesting point, right? Because I think the overwhelming sense is that like you get from senior colleagues is you just need to like sort it out, and sorting stuff out takes time. Whether it's making sure a patient gets home, making sure the follow up is ordered, or making sure, the patient is booked for an operation and actually makes it to the operating theatre. If you've got a consultant who's going to come in and help out with the operation, and your job is primarily to sort that patient out, there are so many different steps. So if there's no one else to help you out, then the buck sort of stops with you, and it's good and bad.
Yeah, exactly. And then I think similarly we get to the chance to hand over to some of our other like colleagues, and it's quite easy. And a lot of the time I'll be handing over things which probably aren't the funnest thing to hand over. Like you've seen the patient, they have to call up the team, but it's really like sort of collegial in that sense. They just know this is like the nature of it. And I think just generally people that do ED are more so like sort of problem solvers. They're happy to just deal with whatever they encounter. And so if you hand over something that's not so sort of fun, they're just like, oh, we'll just figure it out. It'll be okay.
Yeah, they're definitely some of the most like pragmatic and you know like adaptable people in the ED. They just deal with whatever comes in the door and then makes it work. And I really like that when I was on ED as an intern, you like the last like 45 minutes of a shift, like you're not picking up any patient. You're polishing up all the patients that you've seen or are currently managing, and then you hand over to the next person. And it's so clear cut. You don't take any baggage home, which is a real draw card for the specialty, I think.
Yeah, definitely. And then I thought that was really, I sort of like that chopping and changing. You see a patient for like 3 or 4 hours, and then you can actually like change to a new patient, and it's like different pathology. But yeah, you don't take it home. I don't like, you still think about things that you did at work, but often you think of them as like just medically as a concept. It's like, oh, if I see another patient like this next time, would I do the same thing? So it's more, yeah, like academic in that sense. Yeah.
Fair enough. And so let's go back to like where it all started. So you finished high school, and then did you go straight into medical school after that, or did you do an undergraduate degree, or what was your sort of pathway into med?
Yeah, so I was lucky enough to get straight into medical school in Western Sydney as well, straight out of high school, and then that's also like a fairly short degree, like 5 years. Um, and then yeah, I've sort of just kept on going since then. So then I went to like did internship and residency at Westmead Hospital, which I really liked as well. I think just generally being like staying in Western Sydney has been really good in terms of the patient population that we sort of serve and how unwell and the patients are, but also like the pathology that you see is quite interesting. Yeah, and then I came across to Liverpool Hospital because yeah, it's like I think they call it the busiest ED in the country, along with like Newcastle. And the ED is well known, like sort of at least in Sydney, for being quite good with their registrars and their well-being and things like that. So I thought I'd come across and change it up, and I think yeah, it's been really good since then.
That's good. And did you have like anything that like drew you to medicine, like at the start, like when you left high school? Like, did you like were you like, oh, I got to be a doctor, or like it's family stuff, or you just whatever your friends were doing, or what sort of drew you to medicine?
I think it's a range of things, right? Like when you first do it, like have that question answered in like medical school, right? And also some of those interviews that you do, you sort of have those like cookie cutter answers. And then I think a lot of the colleagues that I speak to now would be like, oh, if I had known all this about like medicine or how many years of training I would have needed to do, I probably wouldn't have picked it. But even then, they still, love their job right now. They still love doing what they're doing. I think what I come back to is that it's sort of like I know I can do this job, and I know I can do this well, and I know I can help people. So why not would I do this? I think that's, yeah, like if you're capable of it, why wouldn't you try and do it and like help people and actually like have a positive impact? Um, at the same time, sometimes I do think like if I didn't do it, someone else, could have also done it. Um, but yeah, I think it's just about sort of like knowing that you're helping people and trying your best to help with that and like get people, like at least in ED, I'm always thinking about like how do you get people through the door? How do we make them feel better? About like often on their worst days of their lives, right, when they're coming into an emergency department.
Yeah, it's an interesting like point at which you see the patient in terms of the healthcare journey. You see them at the well, I mean, you're essentially the second person, right, who sees them. The first person may be the paramedic, or maybe a family member who drives them in, or the ambulance driver, and then you're seeing that patient when they walk through the door, and you get to see how sick they are, if they're well, and then they may actually change over time, right? Or they may go straight to resus, or whatever it is. So it's a good point at which you know see that patient on their healthcare journey.
Yeah, one other thing that I've started thinking about lately is actually it's quite sort of humbling. At least working in emergency, but I think just working in medicine in general is quite humbling. Like you're seeing people sure in their worst points of their lives, but sometimes they're losing their family members, sometimes they're like being diagnosed with terminal diseases, and I've found that like that humbling part is actually sort of appreciate that in some ways because it keeps you sort of grounded. You realize that anything can happen in your life and anything can happen to other people's lives, and yeah, I think I sort of have enjoyed that more so, like being able to be a part of this significant moment in people's lives, making them feel better, but also taking that back to your own sort of life and well-being. And sometimes that can be negative and positive, but you try to take the positives out of it. Yeah.
And you see how that changes with like people as they grow up in the healthcare space, right? Like I see consultants or even like nurses in charge, like they empathize with people of their similar age and similar like life status. So, I mean, when you first start out, right, you're like a medical student, you don't really see many young people, right? It's a lot of adults or older people. But then you see like when you like the older consultants, and they see someone who's like also like a mum with like three kids, it's a different ball game, right?
Yeah, 100%. I see that all the time. Every different like boss or consultant, when they see a patient, they have a different way of building rapport. And I felt the same way. Like, and like we're talking about, I've gone straight from high school into uni to like becoming an ED reg. I probably feel a bit on the younger side compared to everyone else, and I've definitely felt that. And often I think it actually requires a bit more effort on my end to be able to relate to all the patients and stuff like that. And you're seeing older patients, and being aware of that and things. And I've been so aware of that I'm actually thinking of like taking a year off, expanding my horizons, trying to travel for a bit, see a few different places, and mature up outside of medicine as well. So that's easier to do your job and like more comfortable.
Yeah, it's not a bad thing. I think I'm PGY 3 at the moment, and I feel like PGY 3, PGY 4. There's a lot of people taking that traditional gap year. It's like you've had your feet in the healthcare system for a few years, and now you're like, okay, this is actually what I want to do, but let me take a year off before I actually like gun and like go straight for it.
Yeah, exactly. And that's what so I think next year I'll be taking like a significant time off, and that's why in the emergency program it's super easy to do that. You just tell them you're taking a year off and they're like, okay, cool, we'll just see you back next year. But yeah, definitely I think it's really important because I'll be exactly halfway through my like training. So it'll be 4 PGY, like I'll be PGY 4, having finished 4 years, and then I'll have 4 years left of specialty training. And I think it makes us better doctors, it'll make us like I said, relate more to patients and being able to interact with them, and then also helps with some of that burnout and the amount that registrars and things can get jaded and like the emotional baggage and things like that as well.
Yeah, it's a tricky thing that like registrar status is like probably the hardest, the worst like period, the most burnt out you may get, because you're given so much responsibility, and then you have to like perform and you fill these like boots that you've just been handed, and it can be a lot. If you don't like look after your longevity, it can actually be quite detrimental, right?
Yeah, I think you realize the responsibility. Like once you become the registrar and you realize the responsibility that you have on you, then you realize when you're maybe not working so optimally on like on a specific day, or you're not feeling so great and you're making one or two mistakes, and you're realizing you might not have made those mistakes on another day. I think that's when sort of that really hits home, and then you think I need to sort of you can only work your best and be the best for your patients and take care of your patients if you take care of yourself. And I think I think you get that once you start sort of training, you start thinking about what type of consultant or what type of boss do I want to be, what do I want to have interest in, how do I want to relate to my patients, creating that sort of personality, and that's where you start thinking of working on over the next few years.
And in your like year off, are you planning to do anything like specific, or are you just gonna make it up as you go?
Now it's mostly travel, but we're making up the travel as we go. Probably go to South America for a few months, 4 or 5 months, but mostly just backpacking, figure out as we go, do a few hikes and things. Yeah, I think it's just more about. I think a lot of the time, especially people in medicine, a lot of them they're always doing like we're always doing something. Like if we're not at work, we're doing something on the side. I think we really just need to sit back and maybe have periods of time when you're not doing things.
It's tricky though, right? Because I mean, there's this overwhelming sense that you are falling behind, or that you're not going to keep up with everyone else, and it's very much that type A personality that's like hyper obsessed with working overtime. And as long as you balance it and make it actually fun, and not just have this sense that you're going at 120%. Like I'm more than happy to do stuff in my spare time to improve my chances of getting a job or getting onto a program or whatever. But I'm only running at like 75%. Like I'm not burning myself out. But some people can like really overdo it, right?
Yeah, definitely. And I think it's from similar to medical school. It's almost like when we used to cram for exams or something, right? Like you can really sort of kill yourself for 3 months and just like live under like a shell or whatever, and just study as hard as you can. And I think we try to do that for this, like for the whole of training, which is like really a marathon, right? It's not 3 months; it's 5 years, 7 years. And then at the end of it, you still got to be a doctor and still be a human and relate to your patients. Um, yeah, I think that's changing a bit more now that, like you're saying, like people are taking years off. I think people are realizing that they're actually highly skilled, and you're sought after, and they want you to work here. And that's what happened during like there is a shortage of doctors in general. Um, and then that way you got to have like the sort of the self respect that other people and your employers will sort of respect you, and look after your well being as well. And I think some of the attitudes in at least some of the specialties are changing a bit, and they want to look after their trainees a lot more.
Yeah, exactly. There's a good wave of new attitude and new people coming through. And then in the next 15 years, they'll all be consultants who will have really strong power in terms of setting like limits on job hours and, overtime and all this stuff, which is just better for like the longevity of like healthcare workers in general. Doctors as one, but also all the others, that are involved in it.
Yeah. Something I've been thinking about more so lately is that the sort of framework that some of the older consultants or the culture that we had previously was 20 or 30 years ago, when medicine really wasn't all that complicated as much as it is now. I feel like we don't give credit. It's actually gotten a lot more complicated. We know a lot more than we even knew like 20 or 30 years ago. There's a lot more mistakes you can make. There's a lot more factors to consider. Um, and that's why it's getting more expensive as well, because there's all these different new medications and things like that, and all these new specialties popping up. And it's not just as simple as it was before. And I feel like we don't acknowledge that as easily, or at least the people that went through medicine 20 or 30 years ago don't acknowledge that.
Yeah, it's very interesting. I remember only recently I made a video about like the different specialties that you could do in medicine, and there's like a whole page of them, and there's like 30 different ones, and I'm like, I haven't even like thought that you could do this or that. And you like when you see it on the board, you're like, oh, there's there's a specific field for like radiation oncology, and that's its own thing, and then it's all like other stuff as well. There's a lot of like a lot of different things out there for someone if you're not sure what to do.
Yeah, and those colleges or those specialties didn't exist 20, 30 years ago. That's like, remarkable how quickly we're moving. Yeah. And like, think about it. Maybe in 10 or 20 years, you're going to have like specialties based around AI or like implementing like IT symptoms within health and stuff. Yeah.
Yeah, it's a cool thing. I mean, I'm all for it as much as you can just channel everything, and it's just very much like robotic surgery in the sense it's not dangerous because there's a robot. You just got to train the person using the robot to perform the surgery at the same thing, and then it actually is fine. It just improves everything rather than all this scary thing called a robot.
Yeah, definitely. I've been thinking like I think it'll be sort of implemented over such a like long period that we won't notice it. It'll be like a sort of a tool in our arsenal, and I think a lot of people, I think even on Australia docs, a lot of on the Reddit, a lot of people have been talking about, oh, is it going to take over our jobs? I feel like technology generally doesn't take over our jobs. It just makes us more productive in a very slow manner. Like, and especially in health, to implement AI would take like 20, 30 years, and it'll just make us more productive. Like an ED, instead of seeing like 5 to 10 patients, might be able to see 10 to 15 because I don't have to write notes and I don't have to do certain things. Um, and it's probably better for everyone. Makes health systems more sustainable. The government can fund them. You can see more patients. You can have a bigger impact. You can probably have a more definite impact as well in terms of when you're like prescribing. You can have like computers and AI backing your decisions and stuff like that. So I think, yeah, it will actually be really good. I'm really keen to see what happens.
Yeah, I mean, like as you said, it's going to take ages for it to like come about. The fact that some hospitals are still using paper to write their clinical notes and not a computer just shows you like how long have computers been around for and why are we still not using that, you know? Like the time it's going to take for AI to come into actual, everyday practice is going to be honestly like 20 years for some places.
Yeah, and I think what I think is in the hospital there are so many other jobs that are easier to like automate than our job, like pushing the beds around, like getting the bloods taken somewhere, like a lot of the wardy jobs, taking obs, all those things will happen first before like doctors will have their jobs taken, and or like there will be less jobs for doctors because of AI. And that's, imagine, can you see a robot pushing a bed around in the next 10 years? Probably not. Like, it's probably going to take longer than that. So, yeah.
Yeah, exactly. I feel like, I mean, maybe this is something for like infectious disease patients or, patients under precautions, but you can have like monitors in rooms, much like a video camera or a webcam to have constant monitoring of patients, which is I don't know if that's around somewhere or if I just heard it in conversation somewhere, but I feel like that's a very reasonable thing to do, albeit like all the privacy and security reasons and confidentiality, of course, but that's just one aspect you could implement. There's so many ways that healthcare system could be optimized. Yeah,
Yeah, exactly. And I think it'll help us. Like I said, it makes it more sustainable. Because I think a worry for me generally over the next 10, 15 years is that healthcare is getting more expensive. And especially in Australia, where we're trying to publicly fund it, I'm not sure how sustainable the government can continue to keep on funding it. So it does need to increase in its productivity in some shape or form to make sure that everyone's still being paid appropriately for their training, for their expertise. So I think that's how AI will probably bridge that gap. Right now, it's not getting there yet, but in the next 10, 15 years, it's probably bridge that gap. Yeah.
exactly. Let's go back to like the ED training pathway, like specifically. How how like do you get on? Like if I was, say, an intern thinking about doing ED as a career, what steps would I need to take to get onto the program?
So, like I said, yeah, probably we want to do a few ED terms, like one or two, depending on how much ED experience you've already had. At the same time, I think one of like my colleagues actually mentioned this: the best ED registrar, like the best training you can get as an ED registrar, is the more terms that you do that are non ED, because it's so broad. You really want to be getting experience in like non-ED terms. So a lot of the time, people do like ICU in residency, or you can do a bit of anesthetics, or like other critical care terms, or even cardiology. Sort of, you want to try to focus on getting a broad experience because it's going to be so useful when you actually are an emergency registrar and you know what needs to be referred, what management they provide, things like that. Then probably you sort of try to apply for an ED registrar job when you're PGY3, so after residency. It's either in like an unaccredited SRMO job or sometimes unaccredited registrar job. You have to do at least 6 months in that PGY3 year. And if you're going to a different hospital, sometimes the hospital provides you with non-ED terms to like pad up your experience. So I did some anesthetics for one rotation, and then I also did pediatrics, like Gen Peds, which is really good. And then, like, I felt so much more confident after having seen kids as a Gen P. Like, I was the pediatric reg on nights and during the day and everything, so that was really fun. And especially because I hadn't seen any kids in my first 2 years because I was at Westmead and they have a separate kids hospital and we don't see any kids. And then yeah, after that, you pretty much after you've done 6 months in that PGY3 year, you apply for the college, and that's usually like with a few referees and things and a bit of paperwork and a few $1,000s. They like let you get on to the program pretty fairly. I don't think they reject too many. Like they have a CV and a referee, and I think they still have a recommendation from the ED that you're working at as well. But that's sort of separate to the process of actually getting an accredited ED reg job as well. So then you have to apply for an accredited ED reg job wherever you want to work. And those can range from like 2 to 3, 4 year contracts. And that's always separate. So like the college is completely separate from the jobs that you're going to apply for, and then you sort of just piecemeal together. So you do different rotations when you're applying for the jobs, and you can ask for different rotations. And I think that's one of the things that I like about ED training. Probably only 60% of it of the time you're doing like ED terms. A lot of the time you're doing anesthetics, ICU, pediatrics, like ultrasound, like toxicology. There's trauma terms. There's a lot of stuff that you can do when you're going to different hospitals. Um, and it's all part of like sort of fatigue management at the same time, because yeah, doing as a ED registrar doing for like 40-hour shifts in emergency can get quite fatiguing, especially with the evenings and nights and things. Yeah. I think yeah. So after that, a total of 5 years actually on the training program, so you end up being like PGY 7 or 8. Yeah, until you've like sort of become a what you call like a FACEN, which at which point even after then I think you can generally get a job in ED, like ED's working as a boss, but a lot of people for their own interest do like retrieval medicine, or they go to like work for PEMS or work for like the Children's Hospital to get a further like pediatric like specialty qualification, which is called PEM. So there's a lot of like different interests, or some people do a year to do toxicology as well.
Interesting. Yeah, I feel like there's so many different things that different ED consultants have. Like they bring different skills to the table. Maybe they've had a base in, say, cardiology or orthopedics or something like that. Everyone's got a different story of how they've like come to ED. So, and as you said, like what is it? PEMS, is that pediatric emergency medicine? Is that what it stands for?
Yeah, yeah. Yep, yep. So then that's an extra like year or two where you work in pediatric EDs and you work in pediatric ICU to get that sort of qualification. Yeah, it's quite sort of daunting when you realize once you start becoming a registrar, you realize like 5 years from now, you have to be able to handle anything that comes through the door, and you have to be able to handle it for 4 hours and keep them stabilized. And I guess in metro EDs, you always have help at hand, but they make you have to be qualified to work in like rural EDs where you're going to be 3-4 hours away from any help, so you need to be able to intubate a kid, or that might be 1 years old, 2 years old, and then stabilize them and get them ready for transfer, which can it's a lot of like experience and learning required, and to keep all that stuff in your head for the sort of the rest of your life is quite difficult as well because of the breadth.
Yeah, there's like, I mean, the thought of that to say a junior doctor thinking, oh, like I have to manage whatever comes through the door is like, I don't know, pretty terrifying to some. Some people like, who want to do ED or just, are that way inclined might be like, oh yeah, give me whatever challenge. Like, I'll just adapt to it. It'll be fine. Will work itself out. which is probably the right person you want in that job, you know.
Yeah, and that's how I felt. Like I think I've always been that sort of person. I was like, oh, whatever problem, we'll just figure things out. And I think a lot of the boss job as a consultant is just figuring like the flow of the department. It's very logistical, and actually the college teaches us that. Like even in the OSCEs, I think like two or three of the stations will be around logistical things. If there's a disaster in the ED, if there's all of a sudden a natural disaster outside, and you have 100 people coming into your emergency department, how are you going to handle it? So yeah, it does actually teach us that more about the logistics and like problem solving, because often the medicine you can search up or learn yourself, but it's harder to do all the problem solving and people manage, and work as a team and manage like your juniors as well, and like teaching them.
I feel like when I was thinking about what specialty do I want to pursue, what am I thinking of going into, that was one of the turnoffs for like a job, is that you look at the job of a consultant, and especially an ED consultant, and you think, well, they see some patients, but often they're getting stories from interns, medical students, maybe registrars, some residents who may be seeing this presentation for the first time. They're trying to work out, do I need to see this patient or do I not? And I don't know, this idea of just being handed bits and pieces here and there and managing flow was one of the things that like made me not want to do ED. But I don't know, it like some people like it, you know.
Yeah, I like the nuances of that. Like as in, if a junior comes to you, there's going to be three or four things that you're looking out for, and often the percentages for like the things that you're looking out for. So like, oh, we need to know about these symptoms, um, and then being as efficient as possible, sort of in that regard, and being able to be like, oh, this patient can go home, this patient can stay, this patient can go home, and then at the same time you're able to teach your juniors. That's what I think. Yeah, that sort of drew me to it, and I think I liked the fact that we all of our consultants, we talk to them on like a first name basis. We know them more so as friends, and they always say, always call me by my first name. And I think like being on the same level, they're always seeing patients as well, alongside you. They're not like sitting in an office, or they're not, you're not doing their documentation or anything. It's very like collegiate in that sense, and that's what I draw me to it. But I completely understand it's quite difficult. Like if you don't like dealing with like models of care and like flow and things like that, and it's a lot of bureaucracy, it can be quite difficult. Luckily, I work in a really nice department where like the nursing staff and everyone's like really knows that they have to just sort of work together because of the like scenario that they always face every day and the amount of patients waiting and things like that. So I've been pretty lucky in that sense.
Yeah, I remember in ED, like you have your morning huddle, and it's almost like this pep talk before you like start your shift, and like you're working side by side a consultant and another registrar. Maybe there's a medical student nearby. Like everyone's in that same fishbowl, like working towards the same goal, which is, as you said, it breaks down all that hierarchy, makes it very flat hierarchy rather than oh, you have to call this person Mister or so and so, you know.
Yeah, yeah. And I think it suits different people. Some people actually like that hierarchy and they sort of aspire to be that, person, or be that surgeon, or be that specialist surgeon that is like, seeing different like patients all the time and running three or four different lists and surgeries, and is that professor or expert in their field, and, wants to know those certain niche things, and like do like pioneer new surgeries and things like that. Yeah, but I don't think I was particularly inclined that way. I feel like I was always a bit of a problem solver. Yeah.
But that's the thing, right? It's like a personality like identifier. If you don't vibe with the people who your specialty sort of attracts, then you got to really question, is this the right thing for you? Whereas like, specialist surgeons in like, I don't know, ENT or neurosurgery or whatever, they get super, super good at very specific things, going to do one aspect really, really well, which, for some people, like that's going to be what they want. Whereas ED is a completely different ballpark, like physician training is different, and same thing for, general practice and whatever.
Yeah, exactly. And I think that's the number one rule. Think about the people that you're interacting, like the bosses that you're interacting with, and can you be like them? Do you vibe with them? And I think that's the thing. Even with some of the ED bosses that I see, all of them have a range of interests. They often like, I think a bunch of them are either cycling or they're doing triathlon running, or they always have something or another that's happening on the side, that you can talk to them about. And I just really like that, because they only have those 40 hours in the week that they're spending at hospital. The other thing I'd also mention as a boss, you get like one like admin day as well, so where you can like provide teaching, at least in New South Wales, where you just provide teaching and you're like on the not on the floor, but you're just helping around the department with flow, um, and then like teaching registrars or teaching students or JMOs, or like doing simulations and like or interacting with other departments to improve how we are triaging patients and stuff like that. um, and so in the end you're actually only working 3 days a week clinical, which is much better than the registrar days where you're trying to work 4 days a week and actually quite getting like working pretty hard. So that's the other thing. Yeah.
Yeah, that's one thing I found in ED is that you actually get proper dedicated teaching time where you don't have any patient care. You're just learning for your sake. And like they would do the teaching maybe in the first hour before the shift starts, or maybe it's on like a day that you're not actually rostered. You are just 100% focused on that teaching. Whereas I look at my day and I'm like, well, I could spend an hour teaching or like going to teaching if I'm able to, but I might be in theatre or clinic, or, maybe I have to prep lists or seeing referrals. Like it's just not feasible often.
Yeah, I didn't realize that until very recently, but like our college is they're very cognizant of the fact that like working in an ED, you're not really getting all too much teaching on an everyday basis necessarily, and you're sort of working as a workhorse, and you can actually miss out on a lot of the teaching that you need. And so they've been quite adamant you need to get 8 hours of teaching a fortnight, and most departments are either doing like 4 hours every week, which is like everyone gets time off and they just go to it and they get paid overtime if it's their day off. Or like our department does 8 hours every fortnight and all the bosses cover the floor. So they'll have like double the amount of bosses on the floor and we'll just have 8 hours dedicated to teaching, which is incredible, including lunch. And just having that downtime with your registrars and realizing that people are so invested in, furthering your skills, yeah, it's absolutely incredible. And I didn't realize a lot of the other specialties actually don't get that.
Yeah, it is like very unique in that sense. And like when you said like all the bosses like on the floor, I mean, you just take like surgical consultants for instance. They're in their own theater unless it's a massive combined case with a different specialty, or maybe they need two consultants to help out for a case. They're just in their own space, seeing their own patients, doing their own cases. All the ED consultants in the same fishbowl. They're able to talk. They're able to run patients by them. Not saying that doesn't happen in other specialties, but ED, they're like, often three consultants if it's a big ED during the day working side by side.
Yeah, definitely. And so you can always bounce things off each other. Like often in resusces, yeah, there'll be two or three consultants helping each other out. Yeah, it's actually really interesting. It is very sort of collegiate, even in that sense, between the consultants. You're always interacting with people. I think that's the other thing I also enjoyed, like as compared to anesthetics or something else. Like you're often always interacting with like staff and like juniors and things like that. You're not working by yourself usually.
Yeah. And like I mean, yeah, every field will have its own way where you interact with different people, whether it's in like a clinic or like a multidisciplinary meeting or some conference or whatever. You do get other people's perspectives, but ED primarily is like a very interactive flat hierarchy often, and each day is like a lot of like collaboration, which is really cool.
Yeah, definitely. I think the other thing that I would mention is you do have to sort of have a tough skin. Just generally, I think it's like when you're interacting with so many teams, it's easy to either make mistakes or not have a negative interaction, and I think often that can like sour your day. So yeah, it's important to like have tough skin, realizing that you're trying your best for the patient. I think is what it has to come back to, that you're always trying for the patient. And like if things don't work out in a specific day, that's okay.
Mm. Yeah, I feel like there's often a lot of specialties that get referrals from ED, and they are expecting that they know their patient and would ask their right questions the same way they would do. Whereas ED is like, referring a patient to the specialty because they need that specialty's assistance, which can be missed some of the time.
Yeah, 100%. And I think at the crux of it, the specialty is about whether we can, like, at least the non-resus part of it is about whether the patient needs to stay or go home. And I think there's a certain art to that in itself, like trying to figure out how well this patient is and how well they aren't, and doing it within that like half an hour that you're seeing them. There's a certain art to that, and often that's what like my ED bosses will tell me as well. Is like you're the person that decides that, and you're the one who's trained in that. They're not. Um, and then if you say they need to come in, then you tell them that this person needs to come in. I think at Liverpool it's actually quite sort of understanding, and every hospital has like a different sort of level at which someone needs to be coming to hospital and someone doesn't, just based on their needs of the area and stuff like that. But yeah, I think sometimes you need to, especially in ED, you can get a bit down about it because you're like, I'm not going to be an expert in that area as much as that other person that I'm calling is. But really, yeah, your art is in trying to be like, I know I need to keep this patient in, and I can stabilize them for the next 4 or 5 hours until they sort of get more tertiary management, like more definitive stuff. Yeah.
Yeah. Was there like ever like an experience in like, medical school or like as a junior doctor where you were like, I definitely, want to do ED, like an interaction with like maybe there was like a registrar or like a consultant where you're like, oh, that's really like attracted me to that specialty? Because I know like often I don't know, you sort of like get this momentum from other people who back you in and say you should do this almost. You should do this specialty.
Yeah, I think it's just a range. Like generally, you enjoy ED. Like I think it was my first clinical term was in ED in third year, and then I think one of the experiences which just sort of sounds funny is one of the registrars that I was on with. He had been on with like I'd done 4 days straight with him, and really enjoyed working with him. He's letting me do everything, and then he was like, "Yeah, sorry, I won't see you tomorrow. I'm off to Bali." And I'm like, "What do you mean you're off to Bali?" He's like, "Yeah, well, I've got 7 days off. I'm just off to Bali, and then I'll be back next week." And I'm like, "Do you take any annual leave?" It's like, "No, no, no. It's just had these random 7 days off. So yeah, I'm going to Bali for a week, and I'll see you in 2 weeks." I was like, wow, that's really cool. That would be really fun to do as well. And that's like an odd, like sort of a work-life balance thing that I really remember being like, yeah, I could do that specialty. But then after that, I think it was a lot of the sort of the resusces that I saw at Westmead and things like that, where I was like, this is actually quite enjoyable, and some of the major trauma we were seeing and the breadth of knowledge. And I think that's when I sort of targeted critical care in general, and being able to be at that point for like patients and provide those critical care things like ventilating them, intubating them. Um, yeah, I thought I really enjoyed that, and then I sort of targeted ED after doing a few of the other ones, and thought ED was probably the best for me.
How would you like if someone was like, oh, I definitely know I want to do crit care, and they're like sort of stuck between ICU, anesthetics, ED. I mean, is there like a way you could help differentiate yourself in terms of what would be better, what would better suit you in terms of a specialty?
Yeah, I think it's important to focus on the boss job. Really important to focus on the boss job. Like I did an ICU term at the beginning of this year, and then I really enjoyed it much more than I expected that I would. Um, and one of the bosses asked me, he's like, "Oh, why don't you do ICU?" And I was like I like this job. I like being the registrar, but your job is not that fun for me. Like, and they're like, yeah, I sort of understand it. Our boss's job is like quite boring and that's what you need to focus on, because ICU bosses a lot of the time are rounding on patients, but they're often sitting at a computer. They're not necessarily doing all the procedures. They're looking at numbers at their patients, and then often having family meetings and things like that, rather than being as hands-on. Similarly, in terms of anesthetics, you're often working by yourself. When I did anesthetics, I found for myself that it was really fun doing those intubations. But when you had like 10 intubations in a day, or like 5 to 10 intubations in a day, and then those periods when you're intubating was nerve-wracking for those 2 minutes, and then all of a sudden you'd get relaxed after that. Now, and I was quite surprised, but I found that to be too much. Like I can't have 10 periods where I'm like absolutely have my adrenaline running for almost that long in a day, and then be relaxed in between. Um, and I thought that was quite surprising for me. But I think just generally you have to be able to like do the terms. I would 100% recommend doing the terms, before you decide. Um, so that's why in that PGY 3 year, you can try to do some ICU terms or like anesthetics, and then with some ED as well, if you want to. And there's a lot of people that chop and change, I think. Yeah, so a lot of my colleagues as well will initially want to do anesthetics, and then they did ED, then did a few weeks of anesthetics, and was like, oh, I don't really like this. And then she came back to ED and like signed up for the program. I think, yeah, generally what actually happens is because emergency is easier to get on to, because it's more flexible and you can apply for different jobs. And even mid-year, a lot of people try to do a quick care anesthetics ICU year, and then if they're not liking it, they switch over to emergency, which I think is fair enough because that all that experience is going to add up in the end anyway.
Yeah, I couldn't agree more. And like what you said about the consultant job is so true. I don't think enough people, think about it. Like, because a registrar in whatever field you're wanting to train in is going to be busy. It's going to be very, very, time intensive. But, at the end of the day, ICU consultants, they're rounding, 2, 3 times a day. They're on call. They're looking after these really sick patients and may have 4 or 5 people die in the day and have to have family discussions. In the different token anesthetists, they're going to have that 2 minutes of adrenaline that's scheduled for potentially 8 times a day. If you don't like it, maybe it's not the right thing to do. And you're going to have to like be the bottom line. If someone's deteriorating, you take control of that situation. And ED, you might have that situation, but it's not planned, right? So you might have a sick patient that comes in the door and then you focus on that situation, but it's not like it's planned, and you're going to have to intubate and you're going to have to do all these things. So
And it's once per day. Yeah. Like often, if I intubated a patient, I'm not going to intubate another patient that day, and that's my adrenaline rush. And then I'm at the back, not even in resus, seeing some of the patients in the waiting room. I think that's the one of the best feelings that I like absolutely love. Like we might have at 1 second been in resus, like being with a really sick patient, intubated them, and then 20 minutes later, I'm seeing some waiting room patient that's still like needs to be an emergency, but is not really that unwell.
yeah, it's just your personality type and the actual job at the end of the day. What do you like doing, and what could you potentially do for 30 years is like a possible runway.
Yeah, it's interesting because similarly, because my partner does anesthetics, and before, like I think a lot of the stereotype around anesthetics is that it's easy, but I was very surprised by the stress that I had just for those like 2 minute adrenaline rushes every time an intubation happened, and knowing that you're the like, as in I wasn't personally, even though the boss was there, but imagining being the boss and being you're the last resort here for this patient's airway, it's quite stressful.
Yeah. Do you guys have different personalities, or is your partner just like could potentially do ED as well, or they just chose to do anesthetics, or do you see like a really stark difference in your personality type?
Yeah, I think I would say yeah. She's smarter for one. I'd say that. But yeah, I think it's different personality types. I think a lot of people, some people can focus on like one patient at a time and prefer having the one patient at a time. Where like I think I'm more like I like juggling things and seeing how they land, sort of, and I can deal with how they land. So yeah, I think we definitely do have different personality types to match that. Same way that I think they are like the specialties themselves are very similar, like all the critical care ones. So you sort of um, like share each other's interests, and you can like try thinking about doing like terms in each of them when you're doing them. So yeah, I think it's similar and different at the same time.
Fair enough. Fair enough. Kush, we might try to wrap it up, man. But it's been like super interesting, like having a chat to you, and all these different perspectives from like an ED point of view, but also just like you know, even like work-life balance, just like broader picture, specialization, pathway sort of point of view is really good to hear. I think a lot of people are going to get a lot of benefit from this discussion. But would you, yeah, what piece of advice would you give to someone who was maybe thinking about, doing a career in medicine, and then particularly emergency medicine, and like maybe there's another tip that you like, learned along like the path of like becoming a doctor and maybe it's like a big life lesson that you only found out as a PGY2 resident on like a night shift or something. Or I don't know if there's anything that comes to mind for a learning point.
I think for a learning point is invest sort of in yourself, in your longevity. I think that's becoming more the case, and this isn't becoming like a registrar. I'm realizing that like not only do you have to sort of educate yourself and learn for yourself, but you also have to keep this going for like 30, 40 years and like create your practice and then understand your clinical acumen, but also make sure they don't get burnt out and things like that. So there's I think we have a career that's very structured for like from the beginning of med school till the end almost. And it's easy to get burnt out. So I think it's important to realize this is like, it's a marathon and you need to um, like structure that marathon, like invest in yourself, take care of your well-being, especially in medical school. I think a lot of the time people as registrars right now, like, I wish I'd studied more in medical school. But at the same time, you're also thinking, I wish I'd, had more fun in medical school. So I think it's a bit of both. Like you have to realize that it's going to be a long way there. There's nothing, and I would say there's no like there's nothing at the end of the tunnel. Like even when you're a boss, like it's as stressful. Like I'm thinking how I transitioned from being a JMO to a registrar. I have the same feeling that when you're becoming a registrar to a brand new consultant and you're dealing with all these JMOs talking to you or something like that, you're going to be as stressful. You're still going to be need 3 or 4 years to get used to it. So there's no rush, and I'd encourage people, take time off, go through it slowly, and if everyone sort of starts treating each other better across all the specialties, and start treating colleagues better and things like that, then I think we'll all be better for it. Would create a better environment.
Yeah, I think it's a really nice point to finish on. Like just having this vision of like interacting as like a team, and the team makes up orthopedics as well as emergency, as well as the general medicine team, and like, all these other teams, like they're all part of like one goal, which is to get the patient through hospital and out the other side in like a safe manner. And also what you said about like your longevity, right? People don't think about it that much. Like they get into medicine and they're like, oh, it'd be cool to be like a surgeon, or it'll be cool to like be a GP. But like, what's your runway? What do you like enjoy doing each day? And what's not gonna get you burnt out? Or I mean, sure, it's not going to be like no hard work at all, but what's your runway in this mindset? And if you just can't stomach 6 months in that job, then maybe rethink, is medicine right for you, and is that specialty right for you? Right? There's not a lot of thinking about your 20 year runway. Yeah, yeah.
Yeah, I think that's happening a lot in like you're seeing posts on people being like, oh, I did medicine and now I'm realizing that this is really not for me and I want to try other things. And that's perfectly fine as well. I think that's actually it'd be really nice if we had a lot of people that have done medical degrees and are in other fields, or even working in more admin roles, or actually working in the health department and, actually being able to provide that perspective into medicine. Yeah, I think there's similar like sort of connotations associated with different like not doing medicine or doing a non-clinical role, and I think we've got to break that down. And yeah.
Yeah, no, I could not agree more. But like, there's a lot of people, as you said, they get into medicine for like that, 3 year runway or 5 year runway, and then they're like, oh nah, I actually do not want to do this. And they're like, why did I even get in there? And I'm like, well, I don't know, maybe you're not thinking in terms of the scope that you like. And then as you said, like you're constantly checking in on yourself. Like, is this what I want to be doing? Would I want to be doing something else? Do I need a break? Uh, need self checks all the time. Yeah.
Yeah, exactly. There's no rush. You just keep on investing in yourself, and the only competition is with yourself. It's not with other people. I feel like that's yeah.
Oof. Yeah, that's a good note to leave on. I don't think I can have any comment on that, but let's let's leave it there, Kush. It's been a super interesting chat. So thanks very very much for taking the time out of your weekend to do this, and maybe we'll cross paths in the future.
Yeah, definitely. No worries. Thank you.
All right, so that's the end of that conversation. If you want to be part of something like this, you think you have an interesting story in medicine to share. Maybe it's how you got in, and maybe it's that you got on a different training program or you went through some adversity. If that's something that you think you'd be interested in doing, then send me a message. The link will be in the description, how you can get in touch. If you know someone else that's probably keen to share their story, or you think that they would be a great person to share on this, then definitely link them in and we can get them on. If you want to stick around, there's plenty of other videos on here to check out and keep you informed, keep you interested, and keep you learning more about medicine. So there you go. Otherwise, we'll see you next time. Bye.